Welcome to This Explainer. Today, we're taking a super common, everyday bedside finding, a dull note at the lung base, and we're going to build the diagnostic logic from the ground up. Let's see how we can layer objective data, moving from the first principles of sound all the way to the newest management guidelines. Picture this. You're right at the bedside doing your exam. You percuss the lung base and thud. You get this dull, flat note. It's a classic sensory trigger, right? And your very first instinct might immediately be, aha, pleural effusion. But what if you're completely wrong? Check out this number, 5. There are actually 5 entirely different pathologies that share this exact same dull sound. Mistake one for another and you are heading down the wrong clinical pathway for sure. A dull percussion note, it's never your final answer. It's really just an invitation to gather a few more pieces of the puzzle. So here's our roadmap for today. We'll start with the 5 dullness mimics, then go over the tidal percussion test. After that, we'll differentiate between transitive and exudative effusions, look at current investigation pathways, and wrap up with the latest 2023 BTS guidelines.
All right, part 1, the 5 dullness mimics.
Okay, so dullness fundamentally just means one thing. Air has been displaced. But to find out by what, we really have to look at the whole clinical pattern. With a genuine pleural effusion, the dullness is specifically stony. You're also going to hear decreased breath sounds and decreased vocal resonance, simply because fluid transmits sound incredibly poorly. Next step is lobar collapse. You still get that dullness and decreased breath sounds, but critically, the trachea deviates toward the same side. Why? Because the collapsed lung actually pulls the mediastinum right along with it. Third is a post-surgical chest, like a prior lobectomy. It mimics collapse perfectly, but a thoracotomy scar and some visible chest wall asymmetry usually give it away pretty quick. Now, consolidation is a bit different. It's solid, sure, but it still has patent airways, so it actually transmits sound better than normal lung. Because of that, you get increased vocal resonance and bronchial breathing, which is literally the exact opposite of an effusion. And finally, an elevated hemidiaphragm. This one perfectly mimics an effusion if you're only looking at static findings.
Which brings us to part 2, the tidal percussion test, your ultimate bedside tiebreaker. Since an elevated hemidiaphragm perfectly mimics an effusion on a static exam, we need a tiebreaker, and this maneuver is genuinely brilliant. Here's how you do it. Step 1, percuss down the posterior chest until you hit that level of dullness. Step 2, keep your finger firmly fixed right at that exact spot. Step 3, ask the patient to take a big, deep breath in and hold it. Step 4, percuss again right at that same fixed level. If the note suddenly becomes resonant, bingo! The pathology is super diaphragmatic. Normal lung has physically moved down into that space during inspiration. But if the note stays dull despite full inspiration, well, you've just proven the diaphragm itself isn't descending properly, or there's something occupying the space right below it. Moving on to part 3, transudate versus exudate. So you've used your clinical skills and you've confirmed it's definitely an effusion. Great. But the mystery isn't over. Now we have to understand the fundamental difference between 2 broad categories. Transudative effusions are caused by systemic factors that mess with the body's hydrostatic and oncotic pressures. In these cases, the pleura itself is completely normal. We're talking about conditions like congestive heart failure, liver cirrhosis, or nephrotic syndrome. Exudative effusions, on the other hand, mean there's active, local pathology disrupting the pleura. It's either increasing capillary permeability or physically blocking lymphatic drainage. The major culprits you're looking out for here are malignancy, parapneumonic effusions, and TB. To confidently make this distinction, we rely on the gold standard, Late's criteria. It's a simple 3-part rule. Number 1, is the pleural to serum protein ratio greater than 0.5? Number 2, is the pleural to serum LDH ratio greater than 0.6? Or number 3, is the pleural LDH greater than 2/3 the upper limit of normal serum LDH? Here's the key. If even one of these is true, you are dealing with an exudate. But watch out, because there's a really surprising pitfall here. Diuretics. Imagine a heart failure patient actively being diuresed. That process actually concentrates the fluid in their pleural space, which can falsely flag as an exudate under Light's criteria. It's crazy, right? So if you suspect this is happening, check the serum to pleural albumin gradient. If that gradient is greater than 1.2 grams per deciliter, it proves the effusion is fundamentally transudative, completely overriding those skewed Light's criteria results. It's an exception-based rule that will absolutely save you some major diagnostic headaches. And while we're talking about fluid logic, there are a couple of highly specific, named diagnostic patterns you really should recognize instantly. A rheumatoid effusion, for instance, has a uniquely distinctive signature. You'll see a rock-bottom glucose below 1.6,
a low pH below 730, incredibly high LDH, and get this, rheumatoid factor, floating right in the fluid itself. Then there's yellow nail syndrome. This is a rare but really vital clinical triad, sometimes a tetrad. It consists of yellow dystrophic nails, lymphedema, a pleural effusion, and frequently bronchiectasis. Seeing these together means you have one unified diagnosis, not 3 random, unrelated problems. Okay, let's look at part 4, current investigation pathways. First things first, a standard chest x-ray confirms the effusion. It'll typically spot it once it hits about 200 milliliters of fluid. If there's no obvious systemic cause, like heart failure, we move to aspiration. And listen, ultrasound guidance is now an absolute must. It's standard practice because it heavily reduces the risk of accidentally puncturing an organ. Plus, crucially, it differentiates true fluid from tricky pleural thickening. If you try to aspirate pleural thickening blindly, you're just going to get a frustrating dry tap. The fluid panel standardly gets checked for protein, LDH, pH, stains, cultures, and cytology. If you're suspecting mesothelioma, you can specifically test for pleural mesothelin. And if all of that still fails to give you an answer, well, then we escalate to a CT of the chest or a video-assisted thoracostopic biopsy.
Finally, part 5, the 2023 BTS Guidelines for Malignant Effusions. For symptomatic patients dealing with a malignant effusion, the freshly updated guidelines give us 2 equivalent first-line options. On one hand, you have talc pleurodesis. The big pro here is that it avoids having an ongoing catheter stuck in the patient. But it does carry a higher rate of needing further interventions down the line. On the other hand, you have an indwelling pleural catheter, or IPC. This option offers a shorter initial hospital stay and actually shows improved dyspnea scores at 6 months out. Plus, about half the time, spontaneous pleurodesis occurs anyway, and the catheter can eventually just be removed. The choice here is no longer about one being categorically better. It's driven heavily by patient preference and what fits best with their day-to-day lifestyle.
And this brings us to a genuinely consensus-level rule in the 2023 guidelines: do not intervene on asymptomatic malignant pleural effusions. We treat the patient's symptoms, guys, not an incidental finding on an imaging scan. If they aren't experiencing any discomfort or shortness of breath from the fluid, we absolutely do not subject them to invasive procedures, period.
So, let's pull this whole picture together. Dullness tells you the air is gone. But tracheal position, breath sounds, tidal percussion, and fluid analysis, they reveal exactly what took its place. I want to leave you with this question. The next time your finger meets a dull note at the base of a chest, will you rely on the very first sound you hear, or will you layer the objective data from first principles and let the full clinical pattern reveal the true diagnosis? Thank you so much for joining me on this explainer. Keep asking questions, keep looking deeper, and I'll catch you next time.